It's a great honor to be back here. I value my friendships and colleagues with this society greatly, and congratulations to Alberto and Levent as joining the honorary member club. It was a bit lonely, and it's a pleasure to debate the rookie of the honorary member club, Alberto. I think we see things very similarly, but I will give a little bit of a different spin to what we are talking about. So I don't have any disclosures except to say that I believe prostate cancer radiotherapy is good treatment. And I agree, and you'll see this, that really the data is lacking. So already almost 10 years ago, Lori Klotz and I debated Mac Roach in the Journal of Urology about which therapy has better outcomes. And you can see while Mac criticized the complications of surgery, especially for men above 65 years old, and urologists should be cautious about offering that as the best treatment, Lori and I were arguing that for men under 65 with unfavorable intermediate risk prostate cancer, surgery potentially was the better choice. So we were already viewing it quite differently with who we were talking about treating. Now today, this is what we're going to be talking about essentially, the robot versus radiotherapy. And really what we're talking about is the robot versus what we in English call the kitchen sink. The kitchen sink is full of dishes, and here's my colleague about to take on these dishes. Now, why do I say this? Because really it's not just radiotherapy, but it's multimodal therapy. It's radiotherapy with intensification of either brachy or HDR, angiogen deprivation therapy, which is the real problem for these patients, and then combination with androgen receptor pathways inhibitor, prednisone. So it's really a whole kitchen sink, and this will add up to more issues. So is there data to support radical prostatectomy over radiation therapy? The answer is no, and there are limited prospective or randomized, as well as 13 retrospective multivariable analysis with propensity scoring, and Alberto has shown you some of those. But here is the meta-analysis from Chris Wallace in Toronto that looked at a large group of these retrospective propensity scored studies showing that surgery had a better outcome with regard to overall death and prostate cancer specific mortality. But again, not randomized, and we have to be very cautious. Now, I'm going to show you the same data that Alberto did, but I'm going to spin it a little bit differently. So this is our only randomized trial, the PROTECT trial. But let's start with the patient population, because I think the conclusions Alberto made are not entirely correct with regard to the cohort of patients we may be treating. The PROTECT trial was 77% low-risk patients. They had a 1% cumulative likelihood of dying from prostate cancer. So it was quite clear that it was a group of patients who would not benefit from active treatment, nor was the study designed to compare surgery and radiation. The study was really an attempt to tell us that active surveillance is the appropriate treatment for these low-risk patients, which has certainly gained traction and is the way we treat patients. Surgery in this trial could be followed by either adjuvant or salvage radiotherapy, and radiotherapy a little lower than contemporary doses at 74 Gray with angiogen deprivation. And again, angiogen deprivation could be reinitiated in patients once they recurred with disease progression. And so you've seen this, the survival curves are comparable for metastases-free survival and prostate cancer survival at 15 years. But interestingly, some points as we are a little overlooked, if you look at the active monitoring, by 8 years, 50% of patients had to convert to an active form of treatment. So you could argue that's good because they avoided active treatment and the toxicities of it for 8 years. Now here's the same table that you just saw, but when you look across metastatic disease, angiogen deprivation, the need for it, and clinical progression, surgery and radiation are comparable, but the active surveillance arm had a 2 to 3-fold likelihood of any of these three events happening. And I would argue, and I'll come to this later, when we talk about the risk of secondary cancer, which I'll come to later, I don't believe that this trial was powered to answer the question of secondary malignancy. Although it's reassuring at 15 years, there wasn't an increase in overall cause of death. That does not mean, in my mind, Alberto, that secondary malignancy was different because it's not necessarily reflected in overall death. It wasn't powered for that. So let's go to the other end of the spectrum, because the only randomized trial is not telling us which treatment, it's telling us active surveillance is the right treatment. So here if we go to, again, a retrospective analysis of 1,800 patients with high-risk prostate cancer, you can see they compared prostatectomy, external beam radiotherapy, or external beam radiotherapy with dose intensification with brachytherapy. And you can see in the radiation arm, they got almost 2 years of angiogen deprivation, with brachy only 1 year. But with the brachytherapy, 73% had pelvic irradiation compared to 40%, so slightly different treatments. But what I want to come down to is the prostatectomy, because one of my themes is that avoiding angiogen deprivation is good for quality of life. And when you come down to these 1,800 patients, of which 640 had prostatectomy, you can see that only 24% needed salvage therapy with angiogen deprivation, so 75% did not. And external beam radiotherapy with ADT and prostatectomy were comparable for prostate cancer-specific survival, distant metastases-free survival, and overall survival. However, intensification with brachytherapy was better for all three outcomes, suggesting that dose intensification is an important component of radiotherapy. Now here's an identical type study. Again, 2,200 men, same time period, 2004 to 2012, high-risk prostate cancer, under age 60 from the SEER registry. I'm not going to dwell on it, but I'm showing just the fact that in this study, the blue line, which is surgery, had a statistically better outcome for prostate cancer-specific mortality and overall survival in radiotherapy. Again, to emphasize what Alberto said, that this is somewhat of a trash can of trials, that even though they are attempting to equalize the patients for all the clinical variables, they still don't answer the question well, because we see two different outcomes for which is better in the two trials I just showed you. Now, this trial, though, is from the Martini Clinic, and the goal of this study was to try to apply the CAPRA scoring system from UCSF, which is a risk stratification scoring system, to determine which patients would need adjuvant therapy for their prostate cancer, which I'll get to is no longer a critical variable for us. However, most of these patients, almost 75%, were intermediate risk prostate cancer. And when we look at the low-risk CAPRA, the blue line, the intermediate, the red line, and the high-risk patients, the green line, what is the likelihood of being free of cancer, biochemical recurrence free at 5 years, which if you get to 5 years, you are in essence very likely not to have a recurrence. 91% of the low risk, 70% of the intermediate risk, and 29% of the high risk. So importantly, 70% of intermediate risk patients did not need additional therapies by 5 years, and 29% of high-risk prostate cancer patients did not need salvage therapies. None of these patients had adjuvant therapy of any type. So this tells us that surgery is relatively effective in high risk and highly effective in intermediate risk for not needing salvage therapy. And here you can see the curves going out the 10 years. The green is the high-risk curve for metastases-free survival and cancer-specific survival, still 80% and above for these two metrics at 10 years, 14,000 patients. And if we try to decide who should have adjuvant therapy, the black line is if no one got it. This gray line here is if everyone received it. And if we apply a risk stratification with a CAPRA score, you can see here between 30 and 60% of patients would be considered at the threshold for adjuvant therapy, which again, we've moved to the salvage realm, but it's showing us the outcomes of these patients. So what do we need to consider as surgeons? Implications of germline mutations, nerve sparing or not, extended lymphadenectomy or not, and adverse pathology and the timing of radiotherapy. So This is an interesting paper, and hopefully Nick James will be able to comment. Comes from Rozels, his colleague in London. I've never seen a follow-up to this, Nick, but it was a phase 2 trial that looked at patients with BRCA mutations having surgery or radiation. And on the left, you can see the cause-specific survival for surgery patients in blue and for surgery patients, the blue is non-mutated and the red is mutated. Essentially, the report is no difference in the outcome, but when you go to the right, this is the radiotherapy cohort. Blue is non-mutated, red has a BRCA mutation, and the patients with BRCA mutations at radiotherapy in this phase 2 trial fared much worse, which is always surprising to me based on the mechanism of DNA damage and repair. However, I've not seen a follow-up longer-term publication of this, but it's thought-provoking, at least, and is 10 years old. So what we need to consider is how to approach surgery with regard to the fascial planes, intra, or extra, based on the risk of the patient. It depends in large part on the patient's view regarding the risk-benefit trade-off of cancer control, risk for adjuvant or salvage therapies, and potency, and what the surgeon is able to do and willing to do in the context of each patient. Another way to look at margin status is to use the NeuroSafe. This is from the Martini Clinic. I personally don't use it. I think it's a bit cumbersome, but you do an intraoperative frozen section, and if there's a positive margin, you take the nerve bundle on that side. I find it a little bit unconvincing with regard to ultimately still having negative margins and the likelihood with multifocal positive margins potentially that you're going to take 2 nerve bundles and still not end up with a margin negative case. But if you can work carefully with your pathologist, you can set up such an intraoperative program. So what about the lymph node dissections? We know we can remove more lymph nodes with an extended lymph node operation, detect more positive nodes, especially in the hypogastric area, but there is an increased complication rate that Alberto Braganti has shown, and there's no improvement in survival. So I'm still puzzled why the EAU guidelines recommend in patients undergoing a lymphadenectomy, you should have an extended lymphadenectomy. I know this is a little bit of a debate right now in the EAU guidelines panel. It's hard to justify having a strong rating for this recommendation in my mind, but that's currently still what it is. Now, adjuvant versus salvage radiotherapy. This will avoid overtreating half of the patients. So on the surgical side, this is being a big advance. And so the radical trials of which Noel Clark and Nick James were co-authors, and they're here, this was really a pivotal trial for us because when we look at patients who had salvage radiotherapy, 39% of it, patients received it by 5 years at a median PSA of 0.2, and you can see that the vast majority avoid additional toxicity and costs of radiotherapy because it's unnecessary in this trial, but there's certainly equivalency whether you get adjuvant or salvage with regard to biochemical, progression-free survival at 10 years, and here is overall survival. Paradigm changing, showing us that in fact we can wait, watch PSA, and the triggers in this trial were 2 rising PSAs above 0.1 or 3 rising PSAs as a trigger for salvage therapy. I personally like to use ultrasensitive PSA because I can look at the doubling time in that range, and I favor treatment in a salvage setting when it hits 0.1, but I find the ultrasensitive PSA gives me many more data points to follow along in a higher risk patient. All right, so what are the toxicities? Well, testosterone deprivation is a toxicity, and I find this is one of the biggest problems of the radiotherapy combination in patients, especially in high-risk cancer, because in this trial, almost 400 men had a limited course of androgen deprivation. The likelihood of recovering testosterone at the conclusion of the androgen deprivation was better in patients who actually received GnRH antagonists rather than agonists and who were younger patients. But men who received androgen deprivation for more than 1 year with an agonist clearly had lower rates of testosterone recovery. And even though this was finite ADT treatment, 1 in 6 men remained permanently castrate. And the biggest complaint I hear, and of course, Alberto, I may or not be your case, but the side effects of androgen deprivation are most problematic for the patients undergoing long-term, 12 to 24 months with radiotherapy. Now here we come to the question of secondary malignancy, strongly defended by my colleague from the PROTECT trial. But this is 200,000 patients who had surgery and 200,000 patients that had radiotherapy. And the likelihood of developing secondary bladder cancer was low, but still twofold higher for radiotherapy, 3.7 versus 1.7%. And the likelihood of developing rectal cancer was twice as high, granted only 1% for external beam radiotherapy. And 10 years is not really the endpoint for these patients. We know the biological development of a secondary malignancy really doesn't start to ramp up until you get well past 5 years, more likely past 10 years. And this trial only went 10 years. So I would agree that the likelihood is low, but I wouldn't agree that it's zero or not different, because again, I don't think that was an endpoint that was powered in the PROTECT trial to answer that question. What about the cost? Now this may not apply in Turkey or perhaps in France, but prostatectomy is about a $30,000 cost. IMRT is between $52,000 and $60,000, and if we add the costs of systemic androgen receptor pathway inhibitors, we're looking at a total of almost $200,000. And this, Alberto, is what I would call the radiotherapist tariff on treatment. This is the tariff you've imposed for treatment at almost 4 times the cost. So let's say, does this sound familiar to urologists? Well, I think testicular cancer is our most treatable cancer. Nobody would argue that's where the best cure rates of any cancer. We start with control of the primary tumor by orchiectomy. From that, we get pathologic staging. Based on that, we could consider adjuvant therapies. We have many of them for testes cancer, recurrence. We have salvage therapies. So let's use this as a gold standard paradigm for cancer success. Now let's go to prostate cancer. We start with surgery. We still have pathologic staging risk assessment. We don't use adjuvant therapy unless it was for lymph node positive disease, but we have options there. And then for salvage, we still have options. So we have a full pathway with risk assessment and follow-up. Now, if we start with radiotherapy, there's no pathologic staging. And granted, if we don't have pathologic staging, we don't really have any role for adjuvant therapy. And we could argue that adjuvant therapy isn't so critical anymore because we can use PSA and PSMA PET and so forth to detect. And salvage therapy, unfortunately, I don't think we have great options. And in the PROTECT trial, where 3% needed additional therapy, that was, again, a very low-risk population. That is not the intermediate or high-risk population where recurrence rates after radiotherapy are much higher. So again, I would argue to be cautious about using the PROTECT trial because it's our only randomized trial to say who is at risk for needing a secondary therapy, because that trial was not really designed to answer that question. It was too low risk a population. So in conclusion, the likelihood of a biochemical recurrence-free survival at 5 years is 70% for intermediate risk and 29% for high risk. I think those are very compelling results for monotherapy treatment. Use of selective radiotherapy as salvage, not adjuvant, has really changed the ballgame for surgical patients. We minimize the use of ADT, the side effects, and permanent hypogonadism. There's a decreased risk of secondary bladder or rectal cancer, although those numbers are still low. They're not zero. For us in the United States, surgery is a much more cost-effective option. However, I want to finish on a positive note, so my friend still has a beer with me. I think that hypofractionation and the tests like the Decipher test to determine the need for ADT or the duration and extent of ADT are game changers for radiotherapy patients. I talked to them about this. Unfortunately, in the United States, patients, radiation oncologists are paid per treatment. So hypofractionation, 5-6 treatments, you get paid 5 times. If you still give the patient 7 weeks, you get paid 35 times. So really poor incentivization for radiation therapists to practice state-of-the-art radiotherapy because they make less money, and I think that's too bad. So in conclusion, here's my dishes. End of the day, I get to go home, have a nice dinner with my lovely family, some of which are here. Alberto, he's still at work. He's looking and saying, Chris, maybe I should have been a urologist. Thank you.